As usual, wonderful lecture by Dr. Mohan. And today's my topic is improving treatment success with timely insulin therapy, my experience. This is my financial disclosure. Today I am going to discuss about the case of type 2 DM uncontrolled on multiple oral antidiabetic drugs. Patient by name Venkat, aged around 56 years old and working as a bank manager. His duration of diabetes is 10 years and level of activity is sedentary and weight is 89 kilos and BMI is 29 kilograms per meter square. HbA1c is 9.5% and fasting plasma glucose is 180 milligrams per deciliter and postprandial glucose is 250 milligrams per deciliter, as his major meal is breakfast with respect to his occupation, and his BP is 140 by 90 millimeters per mercury and his creatinine is 1 milligrams per deciliter and his eGFR is 80 ml per minute per 1.73 meters square, and other relevant parameters are high triglycerides and low HDL. And coming to the history, medical history including comorbidities are uncontrolled type 2 diabetes and uncontrolled hypertension, dyslipidemia and neuropathy. That is, and coming to the drug history, the Venkat takes glycoside tablet, glycoside 60 mg twice a day and metformin 500 mg twice a day and vildagliptin 100 mg SR once a day and telmisartan 40 mg once a day and tablet atorvastatin 10 mg once a day at bedtime and tablet pregabalin 75 mg at bedtime. And coming to the other relevant history, he is a non-smoker and non-alcoholic. Coming to the patient concerns, his concerns are mainly he focused on the uncontrolled blood sugars and irregular dietary habits and lack of exercise and his burning feet. And coming to the Biphasic insulin aspart 30 and randomized controlled trials, there are many trials conducted on Biphasic aspart 30. The studies are Initiate 1, Euromix and Action, Once Mix and Easy Mix, and conducted in various countries and number of patients with regimens with Biphasic insulin aspart versus insulin glargine along with OHS or without OHS. In the Initiate study, the number of patients included are 233 conducted in one country. Here the study is between Biphasic insulin aspart 30 twice a day versus insulin glargine once a day. Baseline HbA1c is 9.7 and 9.8. At the end of the study, the reduction of HbA1c is 6.9 and 7.4. And coming to the Euromix study, 7 countries has done the Euromix 2 study, and the number of patients included are 255, and the regimens are Biphasic insulin aspart 30 twice a day along with metformin versus insulin glargine with glimepiride. And baseline HbA1c is 9.2 and 8.9, and end of the study HbA1c reduction is 7.5 to 7.9. And coming to the third study, Action, the number of countries are only one country has done this study, and number of patients are included in this study is 200, and the regimen is Biphasic insulin aspart 30 twice a day with metformin and pioglitazone versus metformin plus pioglitazone. And baseline HbA1c is 8.1 and end of the study HbA1c is 6.5 and 7.8. And coming to the Once Mix study, this study conducted in 15 countries and the number of patients included are 433, and this study Biphasic insulin aspart 30 once a day versus insulin glargine once a day In both cases, OADs are included, the metformin plus glimepiride. And baseline HbA1c is 8.5 and end of the study HbA1c is 7.1 and 7.3. And coming to the easy mix study. This study is conducted in 2 countries and patients included are 521 and the regimens are biphasic insulin aspart 30 once a day versus insulin glargine once a day along with metformin and glimepiride, and baseline HbA1c is 8.2 and 8.1 and end of the HbA1c study is 7.4 to 7.5. Coming to the once mix study design, 469 insulin naive patients with type 2 diabetes inadequately controlled with oral antidiabetic drugs, and HbA1c is more than 7% and less than 11%, and BMI is less than or around 40 kg per meter square. And this study conducted for 26-week period, and initial 4-week period the optimization of the OADs were done. The metformin is maximized to the 2550 milligrams and glimepiride is escalated to 4 or 6 or 8 milligrams of glimepiride, and on one arm biphasic insulin aspart 30 that is pre-dinner along with glimepiride and metformin combination, in another arm insulin glargine before bedtime along with metformin and glimepiride, and randomization was done. And for the first 10 weeks insulin biphasic aspart 30 titrated weekly to achieve the fasting plasma glucose target, and after 10 weeks biphasic insulin aspart 30 titrated fortnightly if fasting plasma glucose target has not reached. Coming to this once mix study, biphasic insulin aspart 30 more effective than insulin glargine U100 at controlling evening postprandial glucose levels. This dotted line is baseline biphasic aspart, blue dotted, and blue line is 26 weeks with biphasic aspart insulin 30, and grey dotted line is baseline with insulin glargine U100, and grey line is 26 weeks with insulin glargine U100. X-axis shows the blood sugar levels, that is from 2 hours before breakfast and breakfast, 2 hours after breakfast, lunch 2 hours after lunch, and dinner 2 hours after dinner, and bedtime, and 2 to 4 a.m. and breakfast levels. At the baseline of the both biphasic aspart and baseline insulin glargine shows more or less equal decrease in the blood sugar levels, but after dinner there is a after 26 at the end of the 26 weeks period, the blood glucose levels after dinner, that is 2 hours postprandial glucose, there is excursion in the postprandial glucose with is seen in the case of insulin glargine U100 but not in the case of biphasic aspart 30. That is, the postprandial glucose excursion is well maintained, well controlled with biphasic insulin aspart 30. So coming to this once mix, biphasic insulin aspart 30 and insulin glargine U100 were clinically equivalent with respect to lowering HbA1c. So this blue graph shows 2 bars. Blue graph shows the biphasic insulin aspart 30 and grey shows the insulin glargine U100. The biphasic insulin aspart 30 reduces the HbA1c by 1.41, and whereas insulin glargine U100 reduces the HbA1c by 1.25. This is from reduction from baseline at the end of 26 weeks. So this shows there is greater 0.16 greater reduction of HbA1c is seen with biphasic insulin aspart 30 and compared with the insulin glargine U100. And once a day biphasic insulin aspart 30 and insulin glargine U100, patients reaching HbA1c less than 7% without hypoglycemia. This x-axis shows overall daytime and nocturnal hypoglycemias, and the percentage of patients, y-axis shows percentage of patients achieving HbA1c less than 7%. So blue color shows bias 30 and grey color shows IGLAR U100. In overall, 20% of bias 30 achieved HbA1c less than 7% and daytime, whereas IGLAR U100 19.4%, and in daytime biased patients are biased, the percentage of patients are 23.1 and IGLAR U100 are 21.6. Coming to the nocturnal side, bias 30, the patient's number is 36.4% and insulin glargine U100 is 39.7%. So similar proportion of patients in both groups achieved HbA1c less than 7% overall and in the absence of any hypoglycemic episode. So coming to the summary of one's mix, HbA1c change from baseline significantly greater with biphasic insulin aspart 30 and significantly lower postprandial glucose with biphasic insulin aspart 30, and similar proportion of patients achieved HbA1c of less than 7% without any hypoglycemic episode. Biphasic insulin aspart 30 reduced HbA1c significantly compared with insulin glargine U100 in type 2 diabetes mellitus. 3 studies demonstrated that patients treated with biphasic insulin aspart 30 had a greater decrease in the HbA1c level in those treated with glargine. See this graph. And no observed difference in fasting plasma glucose with biphasic aspart 30 compared with the insulin glargine U100. So 2 out of 3 studies demonstrated no difference between the treatments, that is CAN 2006 and Raskin 2005, whereas LITEM 2011 showed the difference. And biphasic aspart 30 significantly reduced postprandial glucose increments compared with insulin glargine U100. So in 2 out of 3 studies, superiority of biphasic insulin aspart over glargine was demonstrated, and in the remaining one, no significant difference between the groups was observed. Comparison of the biphasic insulin aspart 30 with insulin glargine U100, the weight gain, a number of trials, 3 trials, sample size 747, estimate weighted mean difference is 1.1, heterogeneity is p.043, and coming to overall hypoglycemia, number of trials 2, only 1 instance, and sample size is 748 and 63% versus 51%, and severe hypoglycemia 1 instance, number of trials 4, and sample size is 1236.98% versus 1.12% estimate. No evidence for higher risk of severe hypoglycemic episodes with biphasic insulin aspart 30 compared with insulin glargine U100. So coming to the comparison of biphasic insulin aspart 30 with Lispro mix 25 and biphasic human insulin, that is premix insulin, that is human mix start, example 30, study design. The number of patients included are 61, and biphasic insulin aspart 30 given at the time of meal and Lispro mix 25 at the time of meal, and biphasic human insulin 30 given prior 15 to half an hour before meal. And the objective is to compare the postprandial blood glucose excursions between the treatment groups. And the design is, this is a randomized open label 3-period crossover trial, and the method is single dose meal test and biphasic insulin aspart 30 and Lispro mix 25 immediately before the meal, as they are the analog insulins, and biphasic human insulin is given 30-15 minutes before meal, and the population 61 patients with type 2 diabetes, and the age is 60 plus or minus 9.4 years, and BMI is 27.3 plus or minus 3.6 kg per meter square. HbA1c is 8.3 plus or minus 1.1%, and diabetes duration is 11.6 plus or minus 6.4 years, and the total of 45 patients were included in this PP analysis population. This graph shows the comparison between the blood glucose levels and the various insulins like Lispromix and the biphasic insulin aspart and biphasic human insulin. There is a significantly better postprandial glucose reduction is seen with biphasic insulin aspart 30. This graph clearly shows the difference compared to the Lispromix and biphasic human insulin. When compared with the Lispromix 25, the biphasic insulin aspart reduces the postprandial excursion by 10%. When compared to the biphasic human insulin, it reduces by 17%. This shows the superiority and greater reductions of postprandial glucose without any hypoglycemia. This is the meta-analysis. Intensification of the insulin therapy with basal bolus or premixed insulin regimens in type 2 diabetes. A systematic review and meta-analysis of the randomized controlled trials. There is no clinically relevant difference in the efficacy of basal bolus versus premixed insulin regimens for HbA1c decrease, risk of overall hypos, weight gain, and insulin requirement. And coming to back to our case, a case of type 2 DM, uncontrolled and multiple OADs, and the treatment interventions. First treatment intervention starts with lifestyle intervention, that is lifestyle modification and therapeutic lifestyle changes, that is doing exercise, at least brisk walking for 1 hour, and coming to the diet, small frequent meals are advised with low carbohydrates. As Sir said that carbohydrate intake should be reduced to 40% of their meal content, and the reduction of weight and cessation of smoking and cessation of alcohol if any. And coming to the change of medication, the dose of glycoside is continued as same 60 mg twice a day, and the metformin dose is escalated to 1000 milligrams twice a day, and vildagliptin 100 mg should be continued once a day. And I add dapagliflozin, the SGLT2 inhibitor like dapagliflozin 10 mg in this case as the patient is overweight or nearly obese. So, and this favors him in giving cardiac protection and renal protection and hepatic protection in future. So I will start here at this stage the SGLT2 inhibitors along with the insulin, because his HbA1c is terribly high, 9.5, and blood sugars are uncontrolled, and the duration of diabetes is long, more than 10 years. So I start in this case biphasic insulin aspart 30 with major meal with once a day, 12 units to start, and titrate and escalate to twice a day to control the fasting plasma glucose and postprandial glucose to the target levels. Usually I advise biphasic insulin aspart twice a day in my clinical practice. And coming to the hypertension, I will add telmisartan with 40 mg plus chlorothalidone 12.5 mg to control his hypertension, and to control his dyslipidemia I add atorvastatin 10 mg with plus fenofibrate 160 milligrams to control his high triglycerides, and to control his neuropathy I will add pregabalin 75 milligrams along with 1500 milli mcg of methylcobalamin to control his neuropathy. If not controlled, I will add tricyclic antidepressants like amitriptyline or nortriptyline. So, practical recommendations. Administer once a day biphasic insulin aspart with the largest meal of the day. Initiate 12 units of biphasic insulin aspart once a day with the most carbohydrate heavy meal of the day. That is how biphasic insulin aspart is initiated. So, practical guidance on dosing and titration of biphasic insulin aspart 30. Recommended dose for insulin initiation with biphasic insulin aspart is 12 units OD once a day. Pre-breakfast and pre-dinner value, if it is less than 80, the dose has to be reduced by 2 units. And the pre-breakfast value or pre-dinner value is less than 80 to 130, is between 80 to 130, there is no dose adjustment is required. And if the pre-breakfast or pre-dinner value is between 131 to 160 milligrams, you have to escalate the dose by 2 units. If the pre-breakfast or pre-dinner value is between 161 to 180, you have to escalate the dose by 4 units. If it is more than 180 milligrams per deciliter, you have to increment the dose by 6 units to achieve the target levels. Coming to the importance of the glycemic control under current situation, according to the American Association of the Clinical Endocrinologists, diabetes and high glucose levels are associated with increased complications, respiratory failure, and mortality in hospitalized patients with COVID-19. And according to the American Diabetes Association, your risk of getting very sick from COVID-19 is likely to be lower if your diabetes is well managed. And according to the International Diabetes Federation IDF, people with pre-existing medical conditions such as diabetes, heart disease and asthma appear to be more vulnerable to become severely ill with the COVID-19 virus. According to the RSDI, Research Society for Study of Diabetes in India, when people with diabetes do not manage their diabetes well and experience fluctuating blood sugars, they are generally at risk for a number of diabetes related complications. So, glycemic control is very much required. Coming to our case, progression to good glycemic control. To start at the initiation, I will start with the 12 units once a day with pre-breakfast. At that time, the breakfast fasting plasma glucose is 150 and post breakfast is 180 and 250. And after 1 month, I escalate the dose to 16 units in the morning and 4 units in the night. And the blood glucose levels come to fasting plasma glucose is 130 and post breakfast is 190. After 2 months, I escalate the dose to 20 units and night dose 20 and 6. And the fasting plasma glucose is 110 and postprandial glucose is 170. And after 3 months, 26, 20 in the morning and 6 units in the evening, the blood sugars are well maintained and fasting is 108 and post breakfast is 160. And pre-dinner is 160 after 2 months and post dinner is 140 and HbA1c reduced from 9.5% at the initiation to after 3 months it has reduced to 7.4 and his body weight from 89 kilograms to and reduced to 84 to 85 because of added SGLT2 inhibitors, where these the normal insulins will not increase the body weight especially, but with addition of the dapagliflozin or the SGLT2 inhibitors and with the lifestyle modification, regular exercise and small frequent meals, the patient has reduced the weight by 4 kilos. So, what are the learnings from this case? So, timely initiation is necessary Yeah, timely initiation of insulin is necessary in patients with type 2 diabetes mellitus uncontrolled on multiple OADs to prevent not only microvascular and microvascular complications and to lead the quality of life. So that is essential. So, and proper counseling can help to overcome the inertia related to insulin initiation, and it is important to address any apprehension about dosing, titration and risk of hypoglycemias. And third one is to achieve good glycemic control, and it's also important to control postprandial glucose to prevent macrovascular complications and macrovascular complications. So the patient achieved desired control with safety with this regimen. Thank you for your patient listening.